Welcome to Theme 2. In this video, we will discuss the screening process in more detail. Throughout the themes that follow, we will be taking you through the process of initiating your client on PrEP, including starting PrEP, staying on PrEP, and cycling off PrEP if your client wishes to do so. We will show you where we are in the process using these visual process clues. The screening process entails following the oral pre-exposure prophylaxis algorithm. We will follow the algorithm and explain the steps in more detail. There are 5 important tests to do before initiating someone on oral PrEP, namely an HIV test, renal function, hepatitis B, screening for STIs, and pregnancy tests. The first test is an HIV test. This is the most important test, as we must exclude HIV before initiating someone on oral PrEP. The reason that this is important is that we do not want to initiate someone on PrEP who is HIV positive. As our national guidelines stipulate, we treat HIV with 3 antiretrovirals and not 2. If we give someone who is HIV positive only 2 antiretrovirals for a prolonged period, we run the risk of developing resistance. The first step is to do a rapid HIV test as per the national guidelines. If someone tests HIV positive on the national algorithm, we should conduct post-test counselling, initiate them immediately on antiretroviral therapy, and ensure adequate follow-up care. If someone tests HIV negative on the rapid test, we must then clinically exclude any signs of acute HIV, which may suggest that someone is in the window period. If the patient has no signs or symptoms of HIV, it is safe to proceed with screening and to initiate the patient on PrEP. If there are signs and symptoms of acute HIV infection, we must not initiate someone on PrEP yet. We defer initiation and repeat the HIV test in 2 weeks. If the client returns in 2 weeks, has a rapid negative test, and the signs and symptoms have resolved, it is safe to proceed the screening and continue with PrEP initiation. If the patient returns and now tests HIV positive on the rapid test, you should proceed with ART initiation. Next, we will discuss some signs and symptoms of acute HIV. It is important to counsel effectively and not to suggest to anyone who has signs of acute viral infection that they are definitely HIV positive. Carefully explain that we are doing this for safety reasons. Signs that may suggest acute HIV include fever, sweating, viral meningitis, generalized lymphadenopathy, hepatosplenomegaly, pharyngitis, a truncal rash, orogenital ulcers, oral or esophageal candidiasis, and cervical adenopathy. Symptoms that may suggest acute HIV include malaise, anorexia, myalgia, headache, sore throat, sore glands, and a rash. When someone is tested negative for HIV, the next step is to assess the level of risk of the patient. This can be quite complicated and requires the development of a rapport with the patient. On screen are some questions that may be helpful in establishing whether or not someone is at increased risk for HIV and may require PrEP. Some questions include: do you ever have unprotected sex? Do you ever have unprotected sex with a partner who is HIV positive? Do you ever have unprotected sex with a person whose HIV status you do not know? And do you ever have sex under the influence of alcohol and/or drugs? We are very careful in our counselling to remain non-judgmental. Also remember, no one particularly likes being told that they are at risk, so keep that in mind when counselling a patient. Saying things like, people whose partners are more than 5 years older than them have an increased chance of HIV, may be more helpful than saying, you are at risk because your boyfriend is older than you. If you feel that a patient is low risk, but they feel that they are at risk for HIV and they request PrEP, We do not deny them access, and this is reason enough to continue with screening. The second step is to assess renal function. We assess renal function because tenofovir and to a lesser degree emtricitabine are both metabolized in the kidney. Therefore, we need to ensure functional kidneys in order to effectively metabolize and excrete this drug. We also know that tenofovir can cause minor damage to an already poorly functioning kidney. For these reasons, it is important to assess creatinine at baseline before initiating oral PrEP. We assess renal function through creatinine clearance. Creatinine is a waste product that is produced continuously during normal muscle breakdown. The kidneys filter creatinine from the blood into the urine and reabsorb almost none of it. Creatinine present in the blood is therefore a measure to predict renal function. We draw blood and send it to the lab to measure creatinine, and from this we must calculate the creatinine clearance. Creatinine clearance is one measure of renal function. A value greater than 60 mL per minute suggests a good renal function, and a value of less than 60 mL per minute suggests poor renal function. The formula for this is shown on the screen. Therefore, anyone with a creatinine clearance of more than 60 mL per minute can safely proceed with screening PrEP initiation. However, if someone has a creatinine clearance of less than 60 mL per minute, then we do not initiate PrEP in these patients. We bring them back in 2 weeks for a repeat creatinine clearance measure. If after 2 weeks the creatinine clearance comes back as greater than 60 mL per minute, it is safe to initiate oral PrEP. If in 2 weeks the creatinine clearance remains below 60, we cannot start PrEP. It is important to work the patient up for common causes such as diabetes or hypertension and refer them for further workup of renal dysfunction. The third test we conduct is hepatitis B. It is important to note that hepatitis B infection is not a contraindication for oral PrEP. The main reason that we test for hepatitis B is because tenofovir in fact treats hepatitis B. But there is a small risk for viral rebound when tenofovir is withdrawn. This is not a contraindication, but more of a warning. People who have hepatitis B cannot have their PrEP suddenly stopped in the same way someone who is not hepatitis B positive can. There are 2 tests we commonly use. Hepatitis B surface antigen, which tests for the actual virus, and hepatitis B surface antibody, which tests for the antibodies produced by the body to the virus. Hepatitis B surface antibody indicates previous exposure, either from a previous infection or from vaccination, and can be a sign of immunity. This is not important to test for unless you are able to offer vaccination in your clinic. Hepatitis B surface antigen is an indicator of current infection. This infection can be acute or chronic. If someone tests hepatitis B surface antigen positive, liver function monitoring and referral to a liver unit for further monitoring is important. We next test for sexually transmitted infections. Remember to screen for STIs and manage according to syndromic guidelines. If you have access to testing, you are encouraged to do so. All STI medications are safe to use with PrEP. If RPR testing is available, one should test for syphilis and then should be managed according to national guidelines. You should do a pregnancy test before initiating someone on PrEP. Current guidelines suggest that high-risk breastfeeding women can be initiated on oral PrEP with adequate counseling. The risk to the baby is very low, as there is minimal drug in the breast milk. High-risk pregnant women can also be offered PrEP in a setting where good vigilance can be ensured and a pregnancy register exists. That was an enormous amount of information, but it basically boils down to the fact that there are 5 important steps in clinical screening. You have to test for and be sure to exclude HIV. You must test renal function with the creatinine clearance test. You have to test for hepatitis B. You must screen for STIs. And lastly, you need to perform a pregnancy test. That is it for theme 2. Remember to answer the questions below and then move on to theme 3. You can come back to this video at any time and watch it as many times as you need to.